So things are a little different in the U.S. than in Asia in terms of the need for live donor liver transplantation, and so I'm going to be speaking from the perspective of a program and a country where there's actually a fair amount of deceased donation. That's the large majority of what we do, and so living donation comes under really tremendous scrutiny. But the point is that even with the number of deceased donors last year, I think we had an all-time record because, as many of you know, there's a huge opiate overdose crisis in the United States. So I think we were up to 8,000 deceased donors last year, which is the highest number we've had ever. But there's still an enormous gap between the number of people waiting for transplant and deceased donors. And so that's why there's still a need for living donor liver transplantation, even in a country like the United States, where you have a very large population of deceased donors that are available. But as you can see from the most recent data from the US, the line at the bottom, unfortunately, I don't have a pointer here, but the line at the bottom is the number of live donor liver transplants done. So right now it accounts for about 4% of the total number of transplants done, liver transplants done in the United States. So really very different than this. Just happens to be Hassan's growth curve over the years, but you can see, I mean, completely the opposite of what you see in most of the Eastern countries and in Asia, where living donor liver transplantation is really the vast majority of the transplants done. The indications for live donor liver transplantation are essentially the same as deceased donors. So deceased donors on the left, living donors on the right. You can see that in the US anyway, alcoholic liver disease, which is shown here in orange at the top, is one of the primary reasons for living donor liver transplantation, along with cholestatic liver disease. And less so in the US than in Asia, but we do living donor liver transplantation in acute liver failure and in high MELD patients, but primarily the high MELD patients are pretty much taken care of with deceased donor transplantation. So in the US, the group of patients who we're really focusing living donor liver transplantation are people with MELD scores somewhere between 5 and 28 or so. Usually over that, a deceased donor organ would be able to become available. But you can see that in the US, the number's been dropping. Last year was the first year that it actually increased a little bit in terms of the total number of living donor liver transplants done, but you can see this is probably less than what Hassan does in a year. That's the whole United States. And it's really because of the donor death issues. So the original donor death in the United States there was one in North Carolina that didn't get very much publicity, but then there was one in New York City that got an enormous amount of publicity, and that's really where the decline in the number of transplants happened. And then there's been subsequent deaths, 3 subsequent deaths since the one in New York. So there's been a total of 5 in the United States. And we know that the risk to the donor is directly related to how much liver tissue is removed from the donor. So the recovery time, the morbidity, the mortality, all increase depending on which lobe you're taking. So left lateral segment being minimal for a child, right lobe or a right lobe with middle hepatic vein actually has the highest morbidity and mortality and longest recovery. A2ALL was a 12-center consortium put together by the NIH in the United States. It was a multi-center trial, both retrospective and prospective, to try to really determine whether the outcomes of living donor liver transplantation were equivalent to, or better than, or worse than deceased donor transplantation. And so that study went on for a total of, as you can see, from 2002 to 2015, these are the centers that were involved. I was originally at the Leahy Clinic in Boston, but now I'm at University of Colorado, that both were part of the A2All centers. And if you look at morbidity, the morbidity associated with right hepatectomy from the A2All studies is about a 38% overall morbidity rate. But you can see that there were certain variables that were seen to increase your likelihood of overall complications. That's the number of units of blood transfused, and biliary complications were also influenced by blood transfusion, hypotension, presumably because there was some kind of problem in the OR, and alkaline phosphatase was shown to be a variable. You can see this is the retrospective is shown in yellow versus the prospective results of A2All for the complication rates in the donors. And you can see that the most common complications were things that happened intraoperatively, surgically, about 16% prospective in the prospective study. Biliary complications were the next most common, with either leak or, with either leak or stenosis. And infection was the next. If we look at the timing of when the donors had complications, you can see that whether it was biliary, infectious, or all complications, it's really within the first 30 days. So unlike a kidney donor where you're looking at very long-term outcome, with the liver donors, it's really that perioperative period that's the most critical. And 95% of the complications are resolved within the first year, most of them, as I said, occurring during that first month. And as I said, in terms of the deaths, during A2All, this was the mortality associated with the patients who were in the A2All study. There was only one that was really thought to be directly related, which was the multi-organ failure. The other ones are questionable. Whether or not the suicide or the substance overdose was related, it's hard to say. Between the first A2All and second A2All, there were 2 deaths in the United States. One was in Leahy Clinic, the other one was in Colorado. And then since this data has been published, there's been 1 additional death at Mayo Clinic in the past, past year. In addition to the overall morbidity and mortality, I published this paper a few years ago looking at near-miss events, where we did a worldwide survey, and we showed that there were certain complications that were directly related to the program's experience. We just happened to divide it into less than 50 cases, 50 to 200, and greater than 200. And you can see near-miss events, aborted donor hepatectomies. These are 2 of the things that were associated with program experience. So the more experience the program had, the less likely they were to have an aborted donor hepatectomy, where they'd get into the operating room and discover something that would prohibit them from continuing. And again, the more experience the program had, the less likely they were to have a near-miss event. The near-miss events basically being something that could have potentially been life-threatening. But you can see that in about 2/3 of programs, a near-miss event occurs, and the overall incidence is about 1%. And so this is also something that really needs to be discussed with the potential donor, in addition to the morbidity and mortality. We know that the complications that we do see are really the tip of the iceberg, that for every death that we see, there are a total of 8,000 near-miss events that occur. So the key is really to try to find the vulnerabilities in your program and prevent the complications before they occur. And so that's what a lot of the focus has been on, is preventing preventable complications, because we know that near-miss events are about 100 times more common than the actual complication. And so in A2All, we did a lot of work with other industries like nuclear power plant and federal aviation to try to come up with ways to make this more safe for donors. In terms of recipient outcomes, we now know from a number of different series, including A2All, in the West anyway, that we're able to achieve as good outcomes, if not better, with living donor liver transplantation in adults compared to deceased donor transplantation. That was a big deal in the beginning, determining whether or not the outcomes were just as good. And then the 15-year experience from live donor liver transplantation from the A2All experience was published a couple of years ago, and we've learned some important things from this study. We know that there's a learning curve of 20 cases, that if your program's done less than 20 cases, you have about an 80% higher risk of graft failure. So that's an important thing that we've learned. We know that that the advantage of living donation is not only from the time of transplant forward, that in fact there's a tremendous advantage to coming to a U.S. center with a living donor, because your likelihood of dying is about half of that of the patients who don't have a living donor option and have to wait for a deceased donor. So we know that the outcomes are as good from the time of transplant on, but that there's a tremendous advantage of reduced mortality on the wait list if you have a living donor. And that's the data, that's probably some of the most important data that came out of A2All, showing that if you go to an experienced center that's done at least 20 live donor liver transplants, you have the highest likelihood of good outcome, of survival, followed by waiting for a deceased donor transplant. Going to an inexperienced center has a higher mortality than just waiting for the deceased donor transplant, and the most dangerous place to sit is on the waiting list. So, so this is probably the most compelling argument that we can give patients in the United States who are waiting for transplant as an argument for moving ahead with living donor transplant, is that their advantage starts from the time that they're waiting on the waiting list, because about half of those patients, depending on which metropolitan area they're living in, can die within the first 2 years of waiting. So in terms of just looking at the final outcomes of the 15-year data from A2All, there was a total of 1,600 transplants that were completed. We eliminated the first 173 because that was the learning curve for each one of the different programs. So the final analysis was done on 1,427 patients, of which 963 were living donors and 464 were deceased donors. And what you can see is that Hispanic was more common in deceased donor. So there were more Caucasians in the living donor transplant group. And in terms of disease type, the deceased donor liver transplant group had a higher incidence of hepatitis C and hepatocellular carcinoma compared to the living donor group. The living donor group had a higher rate of cholestatic liver disease, for instance, primary biliary sclerosis. And then in terms of disease severity, the deceased donor patients were more likely to be in the ICU, more likely to be on a ventilator, more likely to be on dialysis, so they were sicker than the living donor patients in A2All, which is not a surprise, because we knew that that the partial liver grafts did not do as well. And so, as I said, generally the MELD score you can see where we were mostly doing the living donor transplants is in that 11 to 20 range versus the deceased donors, which were generally the higher MELD patients. And then just comparing some of the perioperative characteristics, it's not a surprise the overall OR time was longer for the living donor operation. The ischemic time, obviously much less for the living donor operation. The number of total days in the ICU was a little bit less for living donor, but really no difference in overall length of stay. And then here's the patient survival. You can see the unadjusted survival is superior with living donor, but when you adjust for MELD, for age, for recipient disease type, hepatocellular carcinoma, the outcomes are equivalent, patient and graft survival for the living donor organs. And the primary cause of death was similar in the two groups, except that we did see a higher likelihood of graft failure in the deceased donor cohort and infection in the deceased donor cohort. And that's probably because these patients were sicker. So you were more likely to die with a functioning graft if you had a deceased donor organ, and it's probably because these patients were sicker at the time of transplant. And in terms of retransplant rate, which is shown here in kind of the purple pink, the retransplant rate was higher in the living donor group, and that was primarily because of a higher incidence of vascular thrombosis, hepatic artery thrombosis in general. But the overall death rate was higher in the deceased donor group, again, mostly because those patients were more likely to die of infection. So when the predictors of mortality were compared between the deceased donor and the living donor, the important thing that we got out of this is that there was no difference in overall mortality when you compared a partial liver graft versus a deceased donor. So the living donor grafts performed just as well, but you can see that that in terms of things that were high predictors of mortality, it was related to if the recipient had a malignancy other than hepatocellular carcinoma, if they were older recipients, if they were on dialysis, if they had an older donor. But you can see that their MELD score did not make a difference in terms of predicting overall mortality. And graft failure was similar, but here MELD score did make a difference. So you can see that in this particular cohort of patients, the sicker patients did have a higher likelihood of graft failure. The things, interestingly, that were not associated with mortality was the error of transplant, the year of transplant, whether or not it was a right or left lobe, and how much time the patient spent on the waiting list. So, you know, I think this is a nice summary from Dr. Lee's group in Asan, looking at all of the different things that are necessary if you're going to start a live donor program. It's not just the surgical team. You need a great interventional radiology group because you're going to have biliary complications that are going to need the assistance of your interventional radiologist to help with that. You need to have a group of surgeons who have experience in both, I think, deceased donor and hepatobiliary surgery to have a successful living donor liver transplant program. And, you know, you need the depth in your group so that it's not just dependent on a single surgeon. You need several different people who have the capacity to be able to take care of these problems, because usually the problems come all at the same time. So you need more than one person who's able to really be proficient in this area. So in summary, in terms of in the West anyway, we know that living donor liver transplantation is not only a good option. For a long time, it's been thought to be kind of a marginal or not as good a graft as getting a whole liver graft, but that's really not true. And we know that from the A2AL data, that the outcomes are just as good, if not better. And really what's holding it up in the US is the risk aversion and the issues related to donor mortality and the litigation that goes along with that. But we should be offering it to many more patients than we are offering it to, because we know that the outcomes are comparable, the cause of death is similar, and your likelihood of dying waiting is significantly less if you have a live donor transplant. So that's just kind of a quick overview in terms of the experience from the US anyway. And so now maybe both Dr. Kawasaki and I can sit up front and we can answer questions that people have.